Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Hey, guess what?
What?
We're going to do something different today.
Okay, everybody, hold on tight. Things are changing drastically here at the podcast.
Instead of talking about 3 articles, we're going to talk about 2.
You can send in all of your concerns in our feedback section if this is really blowing your mind.
Right. Well, I don't think anybody's going to care. Anyway, what are we going to talk about? We're going to talk about one article that presents a new model of inpatient care rolled out in East England. Very exciting. Remember the number 333. Okay.
It's coming back.
Yeah, not 222, but
4444.
But 333. And the second article is going to be, I find this really interesting, improving practices or improving clinician practices when sharing notes with their patients.
So 2 articles, but 2 really good ones.
Yeah.
So first up, we have Manon Carre and colleagues on embedding recovery to transform inpatient mental health care, the 333 model. So I hope we're saying that right. It's not 333. I think it's 333.
333.
Yeah, that's what I say. So this is a description of basically what sounds like an almost entire revamping of inpatient services in the east of England. And we're specifically talking about one part of England, the Cambridgeshire and Peterborough NHS Foundation Trust, or CPFT, which serves a population of about 550,000 adults. And I think the context for this is going to be roughly familiar to our listeners in the United States. So over the past 40 years, there's been a trend in the UK towards closing large mental health institutions in favor of emphasizing community resources. Same sort of trend that's been happening here in the States. More recently, the east of England, this particular region, has also had a population influx, there's a housing shortage, and there's also economic pressures from the Great Recession and the like. So all of this has led to bed shortages within the region and also increased reliance on placing people outside of their catchment area and increasing length of stays. So just to give a sense, across the entire UK, the average length of stay is 35.9 days, which I think is probably...
It's quite a bit longer than here in the States right now.
Yes, the heads of our inpatient units who are listening are probably there.
35.9?
That's a very long length of stay for what we're used to in the States. So they undertook like I said, a massive overhaul of their inpatient services in this region to address some of these issues. And the first part was already pretty much in existence. So they had this crisis resolution and home treatment team, which, from what they describe, attempts to treat people in their home and also serves kind of like a triage function. So,
almost like a crisis intervention team sort of thing.
Yeah, it seems like kind of like maybe even a souped up crisis intervention team where they're able to provide more services in people's homes. But again, like our crisis teams here in the States, they're deciding who needs to go and for more inpatient. And then the rest of it is, I think, really the innovative part. And this is the 333 model. And again, among other things, they did a really nice job naming it. It's a good mnemonic because each 3 is going to represent a different level of inpatient treatment. So, and timelines also. You know,
we're laughing about that, but as the article unfolds, you realize how important it is that the community understand the model and contribute to and play a role in the model. So this notion that 333 is readily understandable and memorable is actually not a trivial thing.
No, and it's, it kind of rolls off the tongue and you're able to kind of capture a lot of information in a short way of saying it. And I think you're right. I think it's not trivial. Okay. So what is it? The first 3 is a 3-day assessment unit, which, as you would expect, is focusing on assessing and triaging patients. The second 3 is a 3-week treatment unit, which focuses on treatment and treatment response. I think that's probably would be somewhat familiar to inpatient units in the States. And then the third 3 is a 3-month recovery unit, and that continues treatment and works on rehabilitation. So I think that there's that's kind of the basics, but really, and it's even in the title of the paper, one of the most interesting parts about this model is that it's really recovery focused. So
before, I think it might be worth making clear that this notion of the assessment unit, the treatment unit, and the recovery unit is kind of a sequence.
Yes.
And people, for the most part, people would start in the assessment unit, and if need be, move to the treatment unit, and then if need be, to the recovery unit. But in sequence, as needed.
Yeah, so they're hoping one of their goals is actually to not admit anybody directly to the 3-month recovery unit and to have most people go through the assessment unit, and I think some people go through the treatment unit. But you're right, it is thought to be kind of a sequential stepwise model. But again, even within that, they really have embedded recovery into the model. So just as an example, the 3-day assessment unit's recovery goal is finding and maintaining hope among individuals who feel that all is lost. So this is kind of revolutionary, actually, I think. I mean, if you think about our emergency departments, which are sometimes treating people on a 3-day timescale, I don't think that ERs have, finding and maintaining hope for people who feel that all is lost as sort of a guiding principle.
No, I would say that they would probably think that would be out of scope.
Exactly. And they also are really drilling down on these timelines. So the assessment unit is operating on an hour-by-hour timeline. The 3-week treatment unit is focused on days, and the recovery unit is kind of working on a unit of weeks. But in that 3-day assessment unit, they're every hour has a milestone associated with it. And that's translates to a really granular and comprehensive way of assessing people. So one example is that if somebody's doing a jigsaw puzzle in the assessment unit, it's an opportunity to assess for concentration. Or if somebody's in a group and they can look to see how people are socializing. So they're really operating on a very granular time scale in terms of the work that they're doing on each of these units.
So the paper has a really wonderful table or box, actually, which delineates for each of these components of the system sort of the key challenge, the key recovery focus, the key functions, and kind of what is new. It's really worth taking a look at.
Yeah. So the paper is really doing two things. It's kind of describing the implementation and the model and the recovery goals. And then they're also using data from April of 2015 to March of 2017 to see if the model was meeting both NHS benchmarks and also their internal targets for bed reduction, patient flow, length of stay, and bed occupancy. So why don't we start with just those and seeing what the paper found in terms of, or the study found in terms of those outcomes. I think the take home is that they really came close to or met almost all of their targets. So just taking a couple examples. After the implementation, they were able to reduce their beds in the region by 44%. And that's compared to a 17% reduction across the UK. So they're also able to meet their patient flow goals, which is really important. It seems like from reading the article that if there's not flow through the system, the whole model kind of would probably fall apart in some way. So what they wanted are for people in the assessment unit, that's the 3-day assessment unit, they wanted 70% or more of those people to return back to the community. And as you said, they actually exceeded that goal with 74% of patients from the assessment unit going back into the community. On the other side, going from the assessment unit to the 3-week treatment unit, they wanted to have less than 30% of people doing that. And they were also able to exceed that goal with 25% of people going from the assessment unit to the treatment unit. So similarly, for people who are in the treatment unit, that 3-week treatment unit, they wanted less than 20% of them to be going to the 3-month recovery unit. And again, they were able to exceed that goal. So just 16% of people from the treatment unit went on to the longer length of stay recovery unit. So they're also either at or around their goals for length of stay. And again, you can think of the length of stay as being explained in the title of the model. So the goal median length of stay for the assessment unit is 3 days. They were actually at about 5 days for that, but they were able to meet the 3-week and 3-month goals for their targets for the other 2 units. And then just to give a sense, across the whole system, the median length of stay was around 6 days compared to around 36 days nationally. So they also had a bed occupancy target of 85%, and they were, again, able to exceed that at 81% bed occupancy. And just to get a sense of that, there were no nights over the study period where there was not a bed available in the system.
The thing about bed occupancy is that there's at least 2 reasons to limit it. One has to do with the desire to always have a bed should somebody in the community need it, and they were able to meet that, to have that situation. Also, there's an argument to limit bed occupancy really for safety. In other words, not to have hospitals really at their capacity, which can cause dangerous types of situations.
And their goal was based on guidelines
from the Royal College.
Yes.
Yeah.
So I think that the results are very impressive on their own. But as we mentioned before, one of the other really interesting parts of the paper is that it's also about both implementation and how they made this into a recovery model. Like, you could see how decreasing length of stay, decreasing beds could be very antithetical to recovery goals. And so it was really important for the designers of the model to make sure that this was a recovery-oriented intervention. And as you were mentioning, that people bought into it in a way. And so a lot of the rest of the article is really about how they were able to do that.
Yeah.
And so one of the things that they're really trying to do is change minds around the providers about what happens on inpatient units. And so they're talking about silos. They kind of have a couple sayings, some of which I don't know if they translate so well from the UK to America, like top to tap, I am here to help you, help yourself. But I think the idea is to embed recovery kind of within the ethos of the entire unit.
Yeah, and it's about creating a vision that everybody buys into. And that takes, really careful inclusion of stakeholders, I think, in the conversation about, what this is going to be and how they're going to implement it.
Yeah, so they did 5 stakeholder events, which sounded very comprehensive. They really put in a lot of thought about how staff and resources were going to be reallocated with all of those bed closures. It seems like it was very deliberative. And again, at every step in the design and execution, recovery was really kind of front and center. And one thing that I think we both stood out for us, along with having the recovery goal, the assessment unit, according to the paper, the people who work there think of themselves as hope vendors.
Yeah, which is just like emergency rooms, in the United States. Hope vendors, right?
I'm not sure which emergency rooms you've been in, but I would like to see them.
I think when you read, particularly the sort of the second half of the article, it sort of makes the case that the system, with all its constraints, at least in this geographic area, could build a recovery-oriented inpatient system for the population, while maintaining budgets and being practical. The paper does list a couple of limitations in terms of, how generalizable is this? What more do they have to do? I think, again, it's worth reading the paper. It's there. I think that it might be difficult to achieve this exact kind of setup in the fragmented system that is really characteristic of the United States. But again, I think it's really inspirational and should be aspirational for us in the United States.
So next up, and last up today, we have Dopa and colleagues on the impacts of a web-based course on mental health clinicians, attitudes and communication behaviors related to the use of open notes. So I had not realized that there's an organized movement going on right now towards sharing progress notes between clinicians and patients. And that's called, as they allude to in their title, open notes.
Yeah, and really it's an overall push toward transparency in the medical record, and so that it's not secret.
Yeah, and there are people who are specifically advocating for this, and the paper itself points towards opennotes.org, where I myself learned that the idea for sharing notes goes back to the early 1970s, kind of gained some steam in the 1990s and 2000s with HIPAA and the increasing use of EMRs, and then really started taking off about 10 years ago with some major health systems implementing open notes. And one of those major health systems was the VA, which in 2013 allowed patients who used their online portal to view clinical notes. So this idea, open notes, has some research to back it up, helping patients feel more in control, improving their understanding of their health issues, remembering what their plan of care is, and also increasing trust. But at the same time, there are concerns from both the patient and the provider about sharing notes between providers and patients. And I can definitely relate to this, having written notes that I don't think would be... I would have to change my practice in writing my clinical notes if I were going to be sharing them with patients. And maybe that's something that should be an eye-opener for me about what I'm including. But so this team has actually done a lot of the prior research in this area, and they had found that providers have been concerned about patients reading notes and becoming worried about their mental health. Some thought it would strengthen relationships with patients. Others thought that it might be more harmful. I really like this one kind of set of statistics that they provided that really point to these mixed feelings, where 85% of providers agreed with the statement, making medical record notes available online is a good idea. So great, sounds like we should move forward. But then almost half of them also said that they would be somewhat or very pleased if the practice were discontinued.
It's like, just as long as it happens to the other guy.
That's right. That's going to happen in the office next door. Right. But I think that's great for them.
And I think just to take a moment for our listeners who are clinicians who write notes, or not even clinicians or care providers who write notes and charts, think about it. Think about it right now, how you would feel if your notes were open without any kind of evaluation or assessment to any of your clients. It's important to think about.
Yeah, I think a lot of people's hearts might skip one beat. But patients are also concerned about this as well, that there's a desire to discuss the notes with their providers, but a reluctance to actually bring it up during an encounter. There's kind of mixed feelings on both sides. But they've done some work, this research group, on what advice both clinicians and patients would have for clinicians to use open notes more effectively. And those studies are part of the basis for this 30-minute training module that focuses on attitudes towards open notes and also communication about it with patients. So this study is to see if attitudes and communication changed among clinicians after they received this 30-minute training that they had designed.
Exactly.
So it's just to get into the study design a little bit. People were not randomly assigned to receive the training or not. Instead, what they did is they sent out an initial email to all of the 251 VA mental health clinicians working in the Portland VA system. So this is social workers, psychologists, nurses, psychiatrists. 131 people respond. And of those people that responded, they were randomly assigned to either getting the survey training and a post-intervention survey right then, and the other group was assigned to get the surveys and intervention a little bit later. And maybe you can just take a second to explain why that's important.
Yeah, well, so it kind of gives a control such that to test whether just the passage of time or increase or access to open notes is influencing the outcome. So you have a group that got the training and right away and did the pre-post right away, and then you had a group that waited and essentially served as a control for the first phase, and then so that we could see if it's really to try to enhance the internal validity.
So you can say with more confidence that any difference between the pre and post survey was because of the intervention and not because of some other thing that was going on.
Right. Yeah. Exactly. You said that very well, Josh. I think you said it better than I did.
Well, after 20, 23, 24 episodes, I'm catching on a little bit. So here are the results.
It's kind of like a waitlist control. There we go.
See,
okay.
now you said it better.
Yeah.
So there's 113 people who took both the pre-survey and the post-survey after they completed the course. And this is what they found was significant. They found that there were increases in perceptions of ability to communicate with and educate patients about open notes, that there's a decrease among providers in worrying about the negative consequences of using open notes, and that they more frequently educated their patients about open notes access and advised them to read and access them and ask them about their questions or concerns. It didn't change providers' concerns about potential negative consequences for the treatment relationship. So it didn't do everything that they had hoped for, but it did seem to really change behaviors.
Yeah, or at least self-reported behaviors.
That's another important caveat. So you really liked this paper. What was it about it that you felt was both important in terms of the content, but also the kind of idea behind it?
Well, what I really love is the idea that they tested a training in an empirical manner. I think we as educators, and even in clinical practice, we too easily or too readily say, we don't know whether, our training approaches work, and this is just supervision, or, we know it works because it's the way we've always done it. But in fact, I think this paper demonstrates that one can take an empirical approach to a training activity. It's not perfect high science, but to me it gives confidence. The findings give confidence that this training program is helpful in certain ways, and it also gives us clues as to what the training activity might need to do better. And so it's really making ourselves accountable for the training and educational activities that we employ. And I, as someone who's an educator, as someone who's very involved in providing technical assistance, I think this just sets a great example for the field.
And I think that there's, just along those lines, I think that a lot of people who are listening get inundated with varying training requirements. And so I think one thing that you're pointing out is that those trainings should be they should add a lot of value to clinicians' knowledge base, or we should really know that they work. And I have a feeling that not all the trainings that people are required to do have gone through this kind of level of rigor. So it kind of sets a little bit more of a benchmark for what we should be thinking through before we ask people to take some time to
do that. And of course it would be great if we could see if this really translates to different actions on the part of clinicians. And, for me personally, I think that the notion of open notes is where we should be going. I believe in transparency. I believe that ultimately, although there are exceptions to every rule, obviously, that this should be a goal.
38 million people right now have access to their notes, so it's also coming.
So that's it for the day. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We remind you to check out the Editor's Choice topic collections available now. You can sign up at appi.org/ETOCS, appi.org/ETOCS. The next collection we're going to be releasing is going to be on perinatal psychiatry. It'll be kind of a little different. We've done recovery, we've done peer support, and then actually after perinatal, we're going to be doing homelessness. We welcome your feedback on this podcast. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.